This. All right. We're now recording. I want to get in, just promote a few webinars that are coming up before we get into the webinar for today. Kind of CROI recaps. Next week, we're doing a webinar on MPOX, sexual networks, HIV, and activism with speakers Dr. Coletso Macofani and Dr. Chloe Orkin. I hope people will join us, and we will drop those links in the chat now. Thank you, Jason, for doing that. Then in April, it's almost April 25th, we have a fabulous webinar looking at multi-purpose technologies. So things that do more than prevent HIV. That should be extremely exciting, and I look forward to seeing you all there. And Jason's going to drop something in the chat about a cure webinar that's coming up as well. I don't have a slide for that, but there's an exciting cure webinar coming up very soon, and we'll drop the information for that in the chat. But what are you here for today? You are here for Been There, Did That, Research Reflections from CROI 2023. I'm going to take this moment to give a bunch of thank yous. A huge thank you to the European AIDS Treatment Group for all your support during the conference, for the Margarita Breakfast Clubs, for this webinar, creating this beautiful graphics. Thank you, Rocco from EATG. Thank you to the Community Liaison Subcommittee of CROI, to Yanis from WHO UK, who made the Ukrainian translation happen. Speaking of Ukrainian translation, our wonderful interpreters, Stan and Dimitri, who are going to be interpreting today. Now that I'm saying this, I'm going to remind myself and others, please try to speak a little bit slower than normal and stay away from acronyms and colloquialisms or slang to help make our interpreters' lives easier. So if I was really talking too fast before, my apologies, guys. I'll do better. I want to also thank my co-moderator, Devan, who is also a community educator scholar, and all of our speakers. Many community educator scholars will be on the call today, and our wonderful colleague, Dr. Monica Gandhi from the University of California, San Francisco. So this is kind of what it's going to look like. Well, isn't what it's going to look like. This is just a quick snapshot of what's going to be happening. We're going to hear from Dr. Monica Gandhi a couple different times, and we're going to hear from almost all of our community educator scholars. We're going to do one chunk in the beginning and then one chunk later. I'm really excited about these scholars this year for CROI. We had 22 scholars who competed in a really tough field to get scholarships to CROI. You can see they're from all kinds of different countries. Many of them have never been to CROI before. They're all awesome, and you're going to be hearing from many of them today through slides. A lot of them will be live. Some of them gave us videos. So I just want to say this is kind of a complicated webinar. We have a lot of speakers coming in from all over the world. We have translation that's happening. So I want to just extend to ourselves and for all of you some patience and grace if we run into some technical issues, because it could happen. I'm going to just take a little walk down memory lane from CROI. As folks who went to CROI remember, or people who dialed into the Margarita Breakfast Clubs, you didn't need to be registered for CROI to join these. We did 3 of these webinars, early morning webinars during CROI. One focused on the Mosaico trial, one focused on Doxy for PEP, and another one looked at the data gap with regard to cisgender women and children and their involvement in HIV research. Oops, yeah, here we go. And so here's just some metrics if you're interested on who came and how many. You'll notice that one there, we had a very persistent porn bomber. The same porn bomber came every day, was very committed to the cause, and kept things spicy, that's for sure. And if you want to check out slides from any of these, you can visit that website linked below, and we will definitely drop that in the chat again for you. And you know, what is a good webinar series without a playlist? It's nothing, right? So if you are interested in the CROI 2023 MBC playlist, we'll drop that link in the chat in a second. Hopefully, there we go. Thank you, Jason. And you can enjoy that. During CROI, we had a very active WhatsApp group. This was open to people who were registered for CROI and for people who were not attending CROI. So whoever was interested in kind of following along, it's a really great way to stay connected and stay in the loop on things as they're happening at CROI. This happens every year. So if you missed it this year, come back and see us next year. And if you were in the WhatsApp group, you know, give a shout out in the chat. Tell us how much fun it was to have 80 million pop-ups on your window constantly because people were so hyper in that chat. It was fabulous. The other really cool thing that we had this year, for the first time, 30 years into CROI, we had our first ever community networking zone. It was a little basic, but we're going to try to, you know, fluff and fold that and make it a little more exciting next year. But it's great to see that community is starting to take up more space, both physical and metaphorical and contextual and content-wise. We're taking up more space at CROI. So that's really exciting. And speaking of taking up space at CROI, CROI kicked off with an opening plenary. Yvette Raphael was on that opening plenary dais speaking about, and can I have folks please hit mute? She was on the opening dais speaking for the Martin Delaney presentation. Was awesome. If you missed it, you can check out her recording on the website, on the CROI website. Here is just a little snippet of her talk where she really focused in on the power of community, trusting Black women, trusting communities, not only to give our bodies for science, but trust our leadership, our agency, our experiences, and our voices. She basically laid the gauntlet down, like, you don't get to work with us and then ignore us. You listen to us, we're the leaders. Community leads, everyone else follows. And it was a really amazing way to kick off CROI this year. I'm sure everyone will agree. And CROI gave everyone a big gift just yesterday. So as of yesterday, all materials on the CROI website are completely available to folks, whether you were registered or not. They're kind of sequestered for the first month after CROI. But as of yesterday, all those materials became available. So you can go and look at webcasts, you can download abstracts, look at posters, everything is all there for you on the CROI websites. And now, without further ado, we're going to get started here. I'm going to stop sharing my slides. And before I turn things over to my really, truly wonderful co-moderator and partner in crime and pulling this whole thing together, Devan, I'm going to first ask Yanis to come on screen and give us some remarks from WHO Ukraine.
Thank you very much, Jim and Devan. Good morning, good afternoon, good evening, everyone. I'm from the WHO Ukraine country office. Disclaimer, I'm not actually in the country. Unlike my Ukrainian colleagues and friends who are joining today's webinar. I really want to thank you, Jim, AVAC and partners, ZATG, for once again having the opportunity to allow for WHO Ukraine to provide Ukrainian translation. We have fantastic translators, Stas and Dimitri, who've been with the WHO team for a while now, and you know, through the war have been incredible in supporting our meetings. These are very, very difficult times, obviously, for our colleagues and friends in Ukraine, our healthcare workers, our NGOs, our volunteers, and so we really value this opportunity to engage with you in these types of webinars. The war has had and sort of tremendous is not even the word to use. A severe impact on the healthcare system. WHO monitors healthcare attacks by the Russian Federation since February 24th of 2022. There's thus far at least 859 attacks on the healthcare system. 101 healthcare professionals have died as a result of those healthcare attacks on the healthcare system. And that includes our HIV services, our TB services in the country. Ukraine has a high burden of HIV and TB, nonetheless, for many years, the country has made incredible gains in expanding access to diagnosis and treatment for HIV and TB. And despite severe disruptions to services, it's under the leadership of the Ukrainian Public Health Center, working with civil society, and in fact civil society really taking the lead to ensure patients are getting their medications and services are maintained. So I think the critical role that civil society, community-based organizations, and independent volunteers have played since last year is beyond humbling. With all that said, I welcome our Ukrainian colleagues to this and everybody else. I think it's a great sort of a showcase of solidarity with the global HIV community, and again, very humbled and privileged to be part of that Ukrainian effort. Thank you.
And thank you so much, Giannis, and yes, solidarity and love to all of our Ukrainian friends and colleagues. I now want to turn it over to one of the community educator scholars and our co-moderator today, Devan Nambiar, who's going to introduce himself briefly, and then we're going to hear from our first 11 community educator scholars from all over the world. Community educator scholars, you know the order you're being asked to present, so I hope you're paying attention. Devan's going to be calling your name very soon. So without further ado, I'm going to turn it over to Devan and our first batch of rock stars.
Let me just pull up my slides here. Jim, do you see the slide? Just confirm with me.
They look gorgeous.
Perfect. Okay, welcome everyone. So today we have 19 community scholars who are going to be, and you're going to be hearing around 50 different conference reflections from the scholars, along with Dr. Monica Gandhi is going to provide you more clinical updates on that. So I'm just going to go into my first presentation here. So this is basically my highlights, looking at the presentation by Dr. Janet, discussed the diversity of human leukocyte antigens, the diversity in age, sex, history of initiation of HIV treatment, duration of treatment, HIV viral reservoirs, and central nervous system. Dr. George spoke about promoting geriatric science for healthy aging and how we age is modifiable. In Ram Gopal's 12-month SOLAR study looked at participants who switched to injectable HIV treatment had significant improvement in treatment satisfaction. In Pinto Cardosa's study of gut microbiota looked at basically participants who switched to integrase inhibitor bictarvate had reduced gut inflammation and an increase in weight gain. In the poster presentation on Mpox, in terms of 3 months after Mpox infection, showed detectable immune markers such as immunoglobulin G and neutralizing antibodies, along with possible suggestion of immune protection. And lastly, cocaine use in people living HIV predicted and associated with greater white lesion in the brain and poorer cognitive function. And my next speaker is Lisa.
Hi everyone, so I'm Adobe from Nigeria, and my top research highlights were the plenary session by Dr. John Nkengason, who talked about the youth and how we are disproportionately affected by HIV/AIDS, and how PEPFAR. I was really excited to hear that the young people are part of the priorities for future research for PEPFAR. I was also enlightened on the importance of including the pregnant and breastfeeding population in research studies. Over time, their exclusion from research has limited the safety information from them, which often delays or limits their access to new products. I also really enjoyed the session on community engagement for advancing research, which inspired me and resonated with my work with the Mosaic Next Gen Squad, a group of young people from across 9 countries who are supporting HIV prevention implementation research in Africa. And most importantly, CROI provided a unique opportunity for me to network with the highest levels of leadership. I met leaders, I've gotten some new mentors who have shared their experiences and are connecting me to various great opportunities. Thank you.
Thank you, Lisa. Next, Mercy Mutoni.
Hello, Masim Tony from Kenya. From my reflection from CROI, as a young woman having attended CROI, there was so much to be hopeful in the current and the future HIV prevention research and programming. I saw a future where HIV and treatment will not be perceived as cumbersome, expensive, and with limited options. For instance, what was really key for me, it was very comforting to learn that DVR has been, dapivirine ring, vaginal ring, has been found to be safe for pregnant and lactating people and their babies. Often communities are left out when it comes to HIV prevention research and designing prevention tools. CROI strongly reinforced the role of community in HIV science, and also participation was very key, and that was very reinforced. Voices of young people, women living with HIV, female sex workers, and other vulnerable population count when it comes to designing HIV prevention and treatment, and we really felt involved during the CROI at 30.
Thank you, Mercy. And next is Tokmo. I think Jim is he coming today?
I think was going to come, but you might just want to
Okay, sure.
recap
I'll
the
just
slides
summarize
quickly
it.
for
Sure.
him. Yep.
So
thank you.
Tokma's highlight was the truncate TB trial in terms of looking at TB treatment for 2 months versus 6 months. So typically the treatment is 6 months. And in this study with over 5 countries and 675 participants in 18 sites, we looked at clinical efficacy of TB treatment. 2 months was equally efficacious as 6 months. So what this means is that for people, this improved treatment adherence over the 8 weeks and a shorter treatment outcome in terms of also helping people adhere to treatment, which reduce drug resistance. And so a lot of this research findings from this study could be directed towards finding and treating more TB patients across the world. Going to next, Catherine. I'm going to play Catherine's video.
Hi there, my name is Catherine Joseph Madebe from Tanzania. I am an AVA Fellow 2022-2023, and I'm delighted to share with you today my insights from the CROI 2023. Actually, it was my very first time attending CROI, so I had so much to learn, so much to look at, and so much actually to do. I'm going back to the community that I serve. And actually, I'm working with the adolescent girls and young women in HIV prevention and STI prevention also. So from CROI, I could say from the researches that I have to learn and things that have been done by the scientists, by the researchers, actually, 2 things or 3 things that came out stood out to me. And in terms of researchers, first, I had to learn about the ToxyPEP. In terms of STI prevention, and I see we have so much more to do, especially for Tanzania as an advocate. I think it's a high time for now, as Tanzania, as a country, as community advocate and educator, to actually start making a way or paving a way for DoxyPEP here in Tanzania, as in terms of STI prevention, since most of the adolescent girls and young women, and of course young people in general, are affected so much, and there's so many issues, policy issues in terms of accessibility to all these services on STI prevention. So adding a new tool is actually a very good approach, and a very good, let's say, a starting point to actually the road of preventing STIs and also fighting the HIV itself. But also I had to learn, I have learned more research and more data on issues around Kabele, because I'm an advocate of Kabele, and also about BVR. So I can say, for the little that I knew before going to CROI, actually I've expanded my knowledge, a scientific knowledge. I could even call myself Dr. Madebe right now. But I had to learn so much on Kabele, the researches that have been done, the successes, and also what to buy there.
Jonathan?
Jonathan is not here if you want to just
Okay,
wait
all right,
for
sure.
him.
So Jonathan also talked about the presentation I mentioned earlier, The Science of Aging by Dr. George Kushal. So in this presentation, Dr. George talked about HIV, people living HIV experience aging-related syndromes sooner than HIV-negative people. So these are some of the biological agings, may be slightly different in terms of the pace, the relevancy, the prevalence of it. So also in this presentation, Jonathan spoke about respiratory disease are higher in people living HIV. So this is something to think about in terms of more research need to be done to understand where and how aging is happening for people living HIV compared to people not living HIV. Yusuf?
Okay, thank you so much. My name is Yusuf Hassan from Nigeria, and basically what really made my CROI was really that a lot of things stand out, but this four at the bottom were really reinforced that we need to have a people-centered partnership and also community. Basically, the Margarita Break Clubs really reinforce that community engagement is really, really important. And also the presentation from Pouchy really give a remarkable tour of science, the challenges and also the future of HIV, and also giving us an insight that really HIV cure and a vaccine remain the unfinished business to ending the HIV pandemic. And looking around the new investigator workshop and also the self-doubt patient really give a really game-changing activity that really, with the right tools, we are really having a HIV cure very soon. And also reinforcing this key activity is also Dr. John, which really reinforced that we really need to put priorities on the young people, the children, and also have a people-centered activities. Just like what we are seeing in today from Uganda, we are seeing some anti-gay law theories that actually reinforce this human right and also some other issues. So the way forward is actually to make sure we put these young people, the children, and also have a people-centered care to make sure that we are actually having a HIV-free generation or HIV-free world. So thank you.
Thank you, Yusuf. Going to Owen.
Devan, you can go ahead
I'll
and
summarize
cover
this,
Owen,
okay.
and
So-
Elri is also not going to be here.
Yes, yeah, okay. So Owen's talked to basically preventable injectables in terms of actually long-acting HIV treatment can be used to reach people with multiple challenges, especially people with treatment resistance and different health profiles. Also in terms of injectable cabotegravir CAB-LA for PrEP among Black MSM and trans women who have sex with men, just demonstrated making it more powerful HIV prevention tool. So this was also found to be safe and tolerable for adolescent girls and young women who are also higher risk of HIV infections. In Elri's presentation, talked basically about treatment for TB in terms of typical TB prevention when you combine with antiretroviral therapy. So it is encouraging for her to see actually many ways to improve the uptake of TB prevention that use methods that could be used from clinical settings to real world settings. And the abstract for those of you who want to check that further is increased TB prevention therapy coverage with integrated community-based IPT and ART. Going to Luis.
Luis, you're on mute still.
Okay, so I apologize for that. So what I want is to echo the words of recognition towards CROI 2023. It is a highly relevant event, and having attended allows me to have access
I
to
know, but it's too much
information.
noise and too much busyness. And hi, Carrie. Oh,
Morning.
look at you all walking.
Luis,
Lu- Yep, Luis, you're back on mute. Sorry about that. Go ahead and you can restart.
Okay. Sorry for the inconvenience.
No
I
worries.
want to echo the words of recognition towards CROI 2023. It is a highly relevant event, and having attended allow me to have access to valuable information that I can now put into practice in my work at Latino Commission on AIDS in New York City. But without detracting from everything I learned during the event, I also want to say that I would like to see in the future a track focused specifically on aging with HIV, long-term survival, and vertical HIV. Likewise, given that this is a global meeting, I would like to see a greater presence of research on HIV in Latin America, as well as research regarding the Hispanic population living and aging with HIV/AIDS in the United States. From the bottom of my heart, thank you so much for the scholarship, and thank you so much for the opportunity. Thanks.
Thank you, Luis. And here we have David. David's not available to attend today. So David talked about basically Don Everett's presentation in terms of community engagement. For those of you who have access to CROI's website, please, I highly recommend watching the presentation by Don Everett. Also, David talked about basically in terms of the importance of also using participants in community engagement as advocates to see them not used just as data participants, but also how they can contribute to further research down the line. He also left the conference optimistic about HIV cure in the future after listening to presentations and the most recent findings from clinical trials and the implications of this data for the state of our treatment across the sector. So thank you. And I think, Jim, right now we are going to turn to you. This is end of round one. I will stop sharing this.
Awesome. Thank you, Devan, and thank you to our first 11 scholars. Can I just say we're on time, miraculously? Yes. How crazy is that? Well, now I have the distinct pleasure to bring forward Dr. Monica Gandhi from the University of California, San Francisco, also a member of the program committee for CROI, so on the inside track in every way. And we are going to be hearing from her twice. She's going to be presenting for about the next 20 minutes, and then we're going to have her finish up her slides after we have round two of those amazing community scholars. So without further ado, I'm going to turn it over to you, Monica. Thank you so much for being here.
Thank you. Can you hear me okay?
Yes.
Okay, really nice to see all of you. So I'm going to go over, hi, Yanis. I'm going to go over a lot of the, actually many of you have mentioned these already in your spotlights, but essentially I want to kind of divide up what I thought was the most important abstracts clinically from the meeting and divide it into updates and treatment for people who are naive or suppressed on therapy, updates in treatment for people with HIV who have resistance to therapy, new strategies for long-acting therapy, and then something on comorbidities and something on prevention. So, there's no reason to talk about, in a way, dolutegravir or bictegravir. There's been many studies that are showing that these are, at the moment, first-line therapy worldwide. So instead of focusing on why they've become first-line therapy, bictegravir and specifically dolutegravir worldwide, because they are potent and they have a high genetic barrier to resistance, we'll talk about some of the side effects that came out from the meeting and long-acting antiretroviral therapy, going from these integrase inhibitors to the long-acting integrase inhibitors. And so if we think about what we saw from the meeting with long-acting treatments, really there are two types of long-acting treatments that are emerging. One is cabotegravir rilpivirine, which hasn't yet been endorsed by the WHO for the planet. It's been endorsed in the US and Europe. And we need, more data on this and more equity on this would be important. One trial that came out of CROI is that we already had these trials called FLAIR, Atlas 2M that showed the cabotegravir rilpivirine given every 4 weeks or every 8 weeks worked. So what did CROI show us? This was something called the SOLAR trial, and it was really randomizing people who were on bictegravir TAF FTC, so-called Biktarvy in the brand name, switching over to cabotegravir rilpivirine every 8 weeks. And how do they do? Essentially, this slide shows us that switching over, kept with very high virologic suppression rates. But importantly, I think what was more important about the study is what people said in the trial. Participants said right before they started it. They said, 43% said, it's hard to take a pill every day. I'm worried about people knowing my HIV status with taking this pill. I'm worried about forgetting. And also it reminds me that I have HIV to take a pill every day. So I think this was revealing in terms of why people wanted to switch over to long-acting cabotegravir and rilpivirine. And indeed, there was high rates of treatment satisfaction in switching over to the long-acting regimen. So just adding to the data that we already had about long-acting cabotegravir rilpivirine. The second long-acting medication that's coming out, that's here actually, but only in very restricted populations, is something called lenacapavir. Lenacapavir is a medication which is called a capsid inhibitor. It's a very new medication, first in class, but its claim to fame is it's only given every 6 months, every 26 weeks, with a subcutaneous injection, not even a deeper shot, but kind of a more narrow shot, like a diabetes, like insulin actually. And so what was presented at CROI was looking at lenacapavir in treatment naive populations, giving in combination with FTC and TAF or other medications that this drug company actually makes. Now, this was such a small study that it's called the Calibrate study, that lenacapavir is not going to be approved yet for patients who are treatment naive. It was just sort of a proof of concept study. And I think the more important thing that came out of CROI is that it has, people did really well on lenacapavir, taking 2 pills with lenacapavir, but there was a little bit of resistance. 3 out of 157 participants in the study did develop resistance. And we'll come back to lenacapavir. Where has it been approved? It's actually only been approved in people who have treatment resistance. We'll come back to that. So let's go to, what did we see with weight and metabolic effects of the therapies from CROI? Well, to kind of put it all together, because there were a lot of studies on weight and metabolic effects, one question was, in that SOLAR study where patients were on BIC, TAF, FTC, and then switched over to the long-acting cabotegravir and rilpivirine, were there any increases in weight or decreases in weight with taking cabotegravir versus bictegravir? And just bottom line, that in the SOLAR trial, it didn't really change weight or metabolic. There weren't any metabolic differences switching over to the long-acting formulation of integrase inhibitors, taking cabotegravir. The weight seemed stable, switching over from oral to injectables. And then there was a big study that said, okay, in the Swiss cohort network, we've been using integrase inhibitors now, starting, for quite a long time. Does being on integrase inhibitors increase the risk of cardiovascular events? Because there was actually a study that was published in the Lancet last year, 2022, that showed that being on integrase inhibitors did look like there was a slightly increased risk of having heart attacks or other cardiovascular events. So this repeated that analysis across a pretty large study, and integrase inhibitors seem to be very safe. They didn't increase the risk of cardiovascular events, which is good because they are first-line regimens worldwide at the moment. So what were other studies that came up in terms of weight? I think putting it all together, what I saw really in terms of weight gain is that efavirenz, our older therapy that we used to use, really is associated with weight loss. it really is emerging that efavirenz is what's called anorectic. It kind of suppresses weight. People don't feel hunger as much, and there's lower weight with efavirenz. Doesn't mean we should be using efavirenz as other side effects, but when people switch off of efavirenz and go on to dolutegravir, that's when the weight gain is seen. And then TAF versus TDF, there was a big study in South African women, and there was also a smaller study in Amsterdam taking off the TAF. Bottom line is that TAF leads to more weight gain than TDF. Switching over to TDF actually led to weight loss in women versus being on TAF. So I think that the bottom line here is that TDF and efavirenz make you lose weight, and going over to TAF or dolutegravir will lead to more weight gain. And that's kind of where we're sitting with the data on weight at this point. Okay, now let's go to people with HIV who are living with resistance. Resistance really has occurred mainly to the NRTIs, to tenofovir, to 3TC, to abacavir, to what was used as the NRTI background. These aren't studies from CROI, so I'm not going to really go over this, but essentially these were studies in the last 2 years, one called Dawning, Nadia, Vaisend, 2SD, that were just showing us that dolutegravir, TDF, 3TC, TLD is the right first-line agent worldwide, because even if you have resistance to nukes, to NRTIs in your past, dolutegravir works very well. So what was shown to us at CROI? This was a study called the DEFT study. And really what the DEFT study showed us is that is that same question, that if you have nuke resistance in your past, you can either be on dolutegravir, TLD, or you can be on darunavir with 2 nucleosides. And actually there was even a third arm, which was darunavir, ritonavir plus dolutegravir. And that arm was a little bit superior. However, it was not superior enough to probably change clinical practice. TLD is likely to remain first line and second line worldwide for now, but we know we always have darunavir or ritonavir if we need it, if resistance occurs to a greater degree. And when I say resistance occurring to a greater degree, no one knows at this point the degree of dolutegravir resistance worldwide, because we are not doing resistance testing in kind of wide population-based surveys yet. There's been setbacks in the HIV response over the last 3 years of the COVID pandemic. And so what this study showed, this was a poster, this was not an oral presentation, but it showed that in cohorts from Canada, Europe, and South Africa, in people who are failing dolutegravir, unfortunately, there is a certain degree of dolutegravir resistance. Again, in those who are failing dolutegravir, a very specific population, and there's a 13.5% resistance rate in patients who are failing dolutegravir. All that means is that the 2 risk factors that came out for failing dolutegravir was being on dolutegravir alone, just being on monotherapy, which is never a good idea. It always should be with nucleosides, or having nucleoside resistance where those nucleosides are not working. So all this study means to me is that never take dolutegravir alone. It's not strong enough to hold up on its own. Hardly any drugs are, meaning they always need to be in combination, and that there is a certain low-level resistance to dolutegravir in those who are failing dolutegravir. So we have to watch resistance across the planet. Okay, coming back to lenacapavir, because I had said it's not going to be approved for naive patients. Where is lenacapavir approved? Lenacapavir is that drug that's every 6 months, every 26 weeks, given as an injectable agent. Where has it been approved in the world? Well, on December 12th, 2022, it was approved for highly multi-drug resistant HIV. If there's a lot of resistance to PIs, to NNRTIs, to NRTIs, then lenacapavir can be used in highly resistant people living with HIV. Now, the thing about this study is called the Capella study, is that unfortunately lenacapavir is not available worldwide. It needs to be made available worldwide to be used in that rare circumstance of what is called MDR HIV, or having a lot of resistance. The Capella study has already been published. This was in the New England Journal last year. So what was the new data from CROI that we saw with lenacapavir? This was some of the data presented at CROI. All it showed us is that lenacapavir, just like this keeps on coming out as a theme, so many drugs, needs to be with other medications to work. It can't be on its own. In fact, the patients in the Capella study who failed lenacapavir didn't have other oral medications to back it up. So there was a certain amount of resistance, but only if lenacapavir was injected on its own without a backup regimen. So has to be taken with other medications to be highly effective, or unfortunately resistance can occur. And remember, lenacapavir is being studied as a preventative agent in the Purpose 1 and Purpose 2 trials, given every 6 months. And then I'll, keeping track that I can go for just a few more minutes, and then we'll come back to the setting. We'll come back for the last 10 minutes. One thing that did come out of the long-acting medications in patients who have treatment experience is that cabotegravir and rilpivirine is usually injected into the buttocks, so usually injected into the gluteal muscles. There was a study at CROI to say, well, can you give it in the thigh? An advantage to giving it in the thigh is that maybe people could give themselves their own injections. And so what this study showed, which is a poster presentation at CROI, is that the drug levels, if you give it in the thigh, were actually the same as giving it in the buttocks, cabotegravir or rilpivirine. But one problem is it did hurt more in the thigh than it did in the buttocks, where there's just more padding there. So, but if need be, there's no difference in drug levels if it was given in the front, in giving it in the thigh as injections. And then, we did a study here at Ward 86 where I'm the medical director, to ask, well, can you use long-acting cabotegravir and rilpivirine in patient populations who are viremic, meaning the way that cabotegravir and rilpivirine have been studied is that they've only been studied in the FLAIR and ATLAS studies in patients who take oral antiretroviral therapy, get virologically suppressed on oral, and then switch over to cabotegravir and rilpivirine. And the FDA only approved these therapies in Europe and the US for patients who are suppressed on oral therapy. But there are patient populations where it's hard to take an oral pill every day. And we treat a patient population at Ward 86 that are all on public insurance. There are high rates of other concomitant challenges in life that make it hard to take a pill every day. There is we actually have a third of our patients living at Ward 86 who have marginal housing, because homelessness is really rising in the city of San Francisco. So we started a study about a year and a half ago to say, okay, let's not just give cabotegravir and rilpivirine to patients who look like patients in the clinical trials who can take oral antiretroviral therapy. Let's give it to anyone who wants it, even if they are not suppressed on oral therapy prior to switching over to cabotegravir and rilpivirine. And so we have 133, we presented data and 133 patients in our clinic who were, we gave cabotegravir and rilpivirine to as long-acting treatment. It was a diverse population, 66% non-white. There was actually 66% had marginal housing. 33% were using methamphetamines. And out of the 133 we started on, 43% were not virologically suppressed. 57 were viremic, had high viral loads actually. And what did we find? We found that everyone who started with suppressed viral loads did fine. They all stayed suppressed on the long-acting treatments. But those who started with viremia, even if they didn't have suppressed viral loads, almost all of them suppressed. There were 2 patients who didn't suppress on long-acting antiretroviral therapy. To be fair, they couldn't take oral ART before we started long-acting, and they couldn't take oral ART after, meaning even right now, they couldn't, they weren't able to take oral ART. So we're glad we tried it in all of these patients, but in general, there was a very low virologic failure rate. It was about 1.5% in our patient population, which is actually the same as in the clinical trials, except that our patient population, a lot of them started with high viral loads. So we're encouraging people we're encouraging clinics, in a kind of controlled way to think about using these drugs, these long-acting agents, even in people who aren't taking oral ART and are virologically suppressed. And I think Jim, am I at, or do I have 2 more minutes?
Technically you have 1 minute, but you know what, Monica, you're going to get 2.
Okay, I'm going to just show one thing, is that even though we've been talking about long-acting cabotegravir a lot, we have such a fractured healthcare system in the United States, at least. I thought it was important to say that even though these long-acting cabotegravir has been approved now for about 1.5 years, as for PrEP, for prevention, only a handful of people in the United States are on long-acting cabotegravir prevention. Only 0.5% of our PrEP prescriptions are using long-acting cab. So we're not really at a point where we're using it a lot here. And certainly, even though it's been endorsed by the WHO as of July 28th, 2022, every country is different. Yanis just said that 100 people have been approved in Ukraine to get long-acting cabotegravir. So we're not ramping this up very quickly worldwide, even though it is superior. And this is a superior agent, meaning long-acting cabotegravir every 2 months really looked like it was superior to daily oral TDF-FTC in both cisgender women and in the HPTN 084 trial, and then in men who have sex with men and transgender women in HPTN 083. But one thing I want to say that's sort of interesting is that in HPTN 084, they were all cisgender women. They were all based in sub-Saharan Africa. All the women, even if you took the drug, you're supposed to take it every 8 weeks, but there was a lot of kind of missed doses and people came in late. There was a lot of forgiveness in the cabotegravir regimen. What I mean is, even if you came in at 3 months, the PK levels were still pretty high in cisgender women. And it does make you wonder, and it raised the question, if women had a lot of forgiveness, meaning could they take their medications late, even 12 weeks? Doesn't mean that the drug companies are certainly, saying we should be giving it every 3 months in women, but there is forgiveness to the regimen. Even if you take it at 10 weeks, 12 weeks, the drug levels are actually pretty high and still conferred protection. So I'll end there because I'm going to come back to talking about prevention. I really want to start with prevention and some opportunistic infections when I get to come back for my last 10 minutes.
Thank you so much, Monica. If you could, thank you for stop sharing your screen. We're going to move on to the next wave of community educators. And Monica and others, there are some questions in the chat. So if you're able to kind of scroll up and see what some of those are and maybe answer them in the chat, we will also have time when we come back after Monica concludes her second wave of remarks for some more QA. But if we can handle some of the questions in the chat now, that would be great. There's also a question from Yusuf in the QA box. So let me share my slides again and get us started with the second round of educator scholars. Let's see, where's my, I think I'm showing you, I thought I was showing you my email there for a second. Okay. So we're going to start here with a video from Mercy.
Hi, my name is Mercy Shibembe and I was one of the community scholars at the CROI conference 2023. My highlight was a few different sessions, conversations and posters that I saw, which were responses to how we tackle adherence. I think so often the ways in which we can tackle adherence are often quite surveillance based and really look at the symptoms of poor adherence rather than the root causes. But I thought that the work being done on using urine tests to track the levels of medicine to then support people and signpost them onto other programs of support were really, really useful pieces of technology that I think could really support people rather than just sort of look at what they're doing and tell them off for their symptoms. So that was my absolute highlight.
Yay, thank you, Mercy. Wherever you are right now, thank you for that beautiful video. Oh, and I think I saw Shakira online. Shakira, would you like to come off mute and share your reflection? Maybe you are not here anymore. Shakira, we can come back to you if you join us. I did see you before, but we will move on. Bridget from the United States, I saw you online. Would you like to come off mute and share your reflections?
Good morning, everyone. My name is Bridget. I'm with the Well Project. My key takeaways were the breastfeeding guideline updates, which I think were really important, and I was happy to see that it was highlighted in a special session. That doxycycline prep doesn't seem to work as well in cisgendered women, which is likely due to the difference in endocervical tissues. And then the Margarita Breakfast Clubs are always a highlight for me. This is my first in-person CROI. I did attend virtually last year. And again, the Margarita Breakfast Clubs were great for helping to break down what we were hearing and how the science is being applied. I highlighted these three things overall because I continue to see a need to have women reflected not only in the research, but highlighted as meaningful inclusion in the science and meaningful inclusion in the research. And that if you protect and prevent women from getting HIV, I really think that that's going to be the way to end this crisis. So thank you again to the core community subcommittee for making sure that community members have a voice and that we are represented at CROI. Thank you.
Thank you, Bridget. Now moving on, we have, my slides. Francis, I saw you there. Are you able to come off mute and share your reflection?
Yes, hello everyone. I'm Francis Grayson Lole from Tanzania. Actually, attending CROI was an enlightening experience that provided me with a lot of valuable insights into the latest development of HIV, STI, COVID-19, and monkeypox research. To be honest, at first I was afraid, thinking that I would not be able to comprehend what would be shared during the conference, as I'm just a community advocate, not a physician. So thanks to the community team led by Jim, Dawn, and Intando for encouraging and guiding us prior to the actual conference with the preparation webinar they organized. From many interesting things I learned, I can say the most important session to me was on science communication during the age of misinformation. The reason being, there are a lot of good works physicians and other researchers are doing, but the actual ground implementation is hindered by the mis and disinformation. And I witnessed this, especially as we were advocating for the uptake of COVID-19 vaccines and the adoption of the new HIV prevention technologies, the DVR and Kabele here in my country. So the session was an eye-opener to me and to easy my work in reaching the policymakers and community with the latest scientific findings. Lastly, as a community advocate, I'm committed to using all the key insights from CROI to advocate for better HIV and STI prevention and treatment programs in Tanzania that are scientifically proven and meet the needs of the community. Thank you.
Thank you, lovely Francis, wonderful. Now, Jeff Berry.
Thanks, Jim. So a small study looked at lenacapavir plus 2 broadly neutralizing antibodies by infusion in people already suppressed, and 90% of people were undetectable after 6 months. The key to this drug, this regimen would be uptake and removing barriers to access and of course the price. The second bullet Dr. Gandhi covered so in detail, so I'll move on to the third, which is we have a 5th person cured of HIV in Dusseldorf, Germany. He had a form of leukemia and was given a stem cell transplant using 2 copies of a rare genetic mutation, making him essentially immune to HIV, similar to Timothy Ray Brown, which gives us clues that will hopefully lead to something that will be scalable in the future. And finally, there was an entire plenary, as you've heard, presentation on HIV and aging and the important role of community advocates. Said Dr. Kuchel, why we continue to focus on whatever disease we study, all of these chronic diseases share one risk factor, and that's aging. Thank you.
Thank you so much, Jeff. Kennedy, are you here? Are you ready to speak?
Yes, I'm here, Jim.
Great, go ahead.
Yeah, so thank you so much. I related to a lot of presentation at CROI, but the first and the foremost that really is close to my heart was the presentation that Don presented on advancing research, the power of community engagement. I have since requested her slides and used them at my last community advisory board and community engagement meeting on the 13th of March. I have also used and added some of these slides into my community engagement slide deck. The other presentation is the one that Monica did, the CAB and reprievering. And I was so excited to learn that there are other regimens in trials, such as this phase 2 open label randomized calibrate study that combined the lenacapavir, which is a capsid inhibitor, in combination with other oral agents every 26 weeks. Then the opening session, as a long-term survivor, the CROI, 30 year of progress presentation made me reflect back and made me walk down memory lane 26 years ago when I was diagnosed. So that time there was death, fear, and a lot of myths and misconceptions around HIV. This session lies another foundation stone in my advocacy history. I reflected on my progress on HIV treatment and prevention, including long-acting treatments, vaccines, and other concepts for HIV vaccines. And I was so happy when Dr. Fauci mentioned the U cause U, because as U cause U campaigner, this has leveraged my advocacy work, as I'll always be referencing his speech. The Monday plenary on PEPFAR, I was also very excited about this because this will now influence me on how PEPFAR would actually advance the engagement and meaningful engagement of people living with HIV. The other presentation is DocStep. Very excited. This one, actually, the following day, I received a phone call from colleagues who wanted to know more about it, because this is one study that we are, keeping our fingers crossed that it can actually pull through. So then there's one study, the session was pediatric and HIV cure. The presentation was on progress in clinical trials of pediatric HIV cure that was presented by Roger Shapiro. So I'm an AIS advocate for Cure Academy alumni. So HIV Cure Science forms part of my community science literacy work. This study has largely done in my country, and I want to leverage on that, and I'll be actually in touch with him so that he can be able to join my community work. And I think, I hope I didn't go over 1 minute. In a nutshell, this is what I can present, but the elephant in the room is little money that is going, little investment that is going into HIV and aging. Everyone living with HIV hopes to age one day. So if we're not going to get a lot of investment in that area, then we are losing the ball. Thank you so much.
Thank you so much, Kennedy. That was beautiful. And our last two reflections here. Neither of them were able to join us, so I'm going to just quickly encapsulate what's on their slides. And again, we'll be sharing these slides. But Sandras from Latvia really talked about the lack of research in the field around alcohol use, and just pointing out the differences between a report in Durban from 2016, and then something that seems to belie that report around unhealthy alcohol use, and he notes the poster there. So thank you for sharing that, Sandras. And I'm going to read Sandro from Italy's reflections. He also shared a whole bunch of blog posts that he did on his website, which are linked there. They are in Italian, but you could probably use Google Translate to get it into whatever language you need. And I'm going to go ahead and read this now. The reason for my presence at CROI is to bring back to my country scientific studies, the state of the art. And now I can't see behind my little screen here. Hold on. Okay, sorry about that. The state of the art on HIV, the innovations that I believe may be useful for Italy and for LGBT people living with HIV in Italy. I tried to understand the state of the art on vaccines, on cure, on treatment, Mpox, PEPFAR, on reservoirs, and why they block the possibility of realizing a cure for HIV. I always have in mind the empowerment of people with HIV so that they can be responsible for their own health and not blindly depend on others. That's why I go to science conferences. We here in Italy have to fight against stigma, prejudice, and a creeping provincialism that makes it difficult even for doctors to promote U equals U. CROI is a unique opportunity to draw on firsthand information without going through the opinion of Italian infectious disease specialists. This is very important to us because it helps us in the work of empowering people with HIV and stimulates us to fight against the backward mentality of many Italian researchers. So Sandro definitely has a point of view here, and I very much appreciate, and I'm sure you all do too, him sharing this reflection. So with that said, we are now in the home stretch. I'm going to turn it over to Devan, who's going to reintroduce Monica, who will take us through the rest of her slides, and then we'll have hopefully a few minutes for follow-up Q&A.
Thank you. Thank you, Jim. Dr. Monica, would you like to come back and present the remaining of your presentations?
I see she's still in the room.
Yep.
Oh, there she is.
Monica.
Hey, Monica. You ran to the bathroom real quick.
I did run to the bathroom, actually. I'm really sorry. Okay.
No worries. It's only been a second. No worries.
Okay.
Thank you.
All right. So, I wanted to go on to prevention next. And actually, I thought this was a really important study that I'm not sure got the amount of attention that I thought it would, which was a very big analysis of women and taking oral PrEP, TDF, FTC. So essentially, this was presented by Ginny Marazzo, and really what she did was look across all these demonstration projects of taking daily oral TDF, FTC among cisgender women. Because remember way back when that there was this idea that women had to take PrEP more adherently, more, 7 doses a week as opposed to 4 doses a week. And really, that's not true. So we were kind of going on mucosal pharmacology thinking, oh, maybe FemPrep and voice didn't work because women need to take drug more. But actually, many of these 11 demonstration projects had available adherence data in them. And really importantly, the study showed that as long as women took the TDF FTC 4 doses a week, they had just as good outcomes as taking 7 doses a week. And I think this puts this just finishes this question that women need higher levels of adherence than MSM and transgender women. Really taking PrEP 4 doses a week is just fine. And And there's really not a difference there with mucosal pharmacology. I think this is very important because that's all it takes. And you take it around the time, as long as you take it 4 doses a week, you're fine. Now, this was already covered in the community talks, but I think I'll go into this a little bit more. We know that doxycycline taken as post-exposure prophylaxis in MSM and transgender women works to decrease sexually transmitted infections, chlamydia, gonorrhea, syphilis across the board. So what about in cisgender women? This was a study that was done in Kenya. And really the question was, okay, does taking doxy after sex decrease STI rates in cisgender women just like it does in men who have sex with men? Importantly, in this large study in Kenya, 449 women, there were actually high rates of STDs, 30% chlamydia. So it is important to say that this would be a very important intervention in women just as well as men. But very unfortunately, taking doxycycline post-exposure prophylaxis did not decrease the incidence of sexually transmitted infections in Kenyan women. And it really wasn't about resistance. The chlamydia was all, was actually all sensitive to the doxycycline. So we don't know exactly why this happened, why we're seeing this difference with cisgender women and men who have sex with men. Right now, there were 2 speculations. Maybe the drug levels were different in the vagina versus the rectum, but you know what? That wasn't shown by another study in the same session that Janelle Stewart presented at, that the doxy levels in the vagina, in the vaginal tissue, looks like they should just be fine to prevent sexually transmitted infections. Maybe it's adherence, but if it is, we need more data on that. Maybe the women weren't taking it regularly, and they said they were, but sometimes it was harder to take it. So we need to look at adherence closely, and we're going to actually do hair levels of doxycycline in this study, but we don't know right now. But it's not approved for cisgender women, and that's unfortunate. Okay, what about one other thing about prevention I want to mention is using the meningococcal vaccine to prevent gonorrhea. Why would that be? Because actually they're both what are called Neisseria species, and there's cross protection. So if you give meningococcal B vaccine, there's a study from France, there was actually a 51% reduction in gonorrheal infections. And that, there's doxy pep works too, but so does giving meningococcal B vaccine. So this is the first time this has been shown, and it's likely that giving meningococcal vaccine is going to have benefit to protect you against gonorrhea, which is a cousin, and they're in the same family. So I think that was helpful to see that we already knew doxy pep works in MSM and transgender women, but this was another study that shows that. But that meningococcal B vaccine also significantly reduces gonorrheal infections. Helpful, because this is a vaccine that's available. Okay, and now I just want to just mention one thing about a drug called islatravir. Remember, we were thinking about islatravir in using it with something called doravirine, and it's a new class of medications. It's called an NRTTI, not a nucleoside reverse translocation transcriptase inhibitor. It's a new class of medications. It actually has very few side effects, except when used at higher doses, it was actually making the lymphocyte count go down. So all of his islatravir studies were stopped, and this important study at CROI showed that actually if you give islatravir at a lower dose, that's when there's no problems with the white blood cell count going down. So now islatravir is going to move forward and the studies are back on, but at a lower dose of islatravir. And then let's end with opportunistic infections. So 2 of these mentioned, I'm really sorry to show these really difficult pictures, but the study that was presented by Chloe Orkin, and you're going to have a session next week with Dr. Orkin, showed that really in patients with low CD4 counts, that's when the monkeypox or the mpox infections were worse. And even though she presented it at the meeting, there was a paper that came out at the same time in the Lancet that its mpox really was worse in those with CD4 counts less than 200. And also CD4 counts less than 100 were the worst. Mortality rate was actually higher in CD4 counts less than 100. So at this point, we have to call mpox an opportunistic infection. We never really seen mpox with HIV because this was our first big global outbreak across the planet. HIV and mpox seem to have an interaction, and it really does cause an opportunistic infection. And then this was mentioned in the community report backs, but is there a way to shorten therapy for tuberculosis? Because it does take 6 months of 4 drugs, actually usually 4 drugs for 2 months and then going down to two drugs for the last 4 months. And so this was a study called Truncate TB. It was presented at the meeting, but then a New England Journal study came out at the same time to coincide with the presentation. And the idea is, could you take 5 drugs? I mean, it's a lot. It's 5 drugs, but shorten the course to 8 weeks instead of the 6 months. And yeah, you can actually, it's actually bedaquiline, linezolid, and then 3 more typical TB drugs called isoniazid, pyrazinamide, and ethambutol. But taking all 5 of those drugs for 2 months gave the same outcomes as taking sorry about that. So taking 5 drugs really for 2 months was just as good as taking, the 4 drugs for the 6 months. And so I'm going to actually end there because I want to have enough time for questions. And thank you so much for listening to me.
Thank you, Monica.
Oh yeah, thank you. Devan, I think we should do some questions live and in person here. We have some time. And I know Yusuf had a couple of questions, or there's a lot of questions regarding weight, and Yusuf had a question in the QA about weight. Yusuf, would you like to come off mute and ask your question so we can all hear it? I think you're still here. Yusuf may have dropped off, so I'm going to answer.
No, I haven't dropped off.
Okay, great. Ask your weight question, please.
Okay. Just wanted to ask 2 questions. Basically, the first was actually around doxycarb. Just trying to know a study in cisgender women showing the opposite with other ANRRS study. What's basically the issue? Is it anatomy, resistance, adherence issues or so? And also the other question I wanted to ask was actually a key question that was unanswered at CROI. How do we reconcile this weight gain issue in Discover and also the placebo arm IPREX? I know there was a slide that shows comparison between these 2. Or is there changes within this TAF when used with woman hepatitis V vaccine that was shown also?
Okay, so the DoxyPEP study, we don't know exactly why it didn't work in cisgender women like it does in MSM transgender women. And I think it's going to end up being adherence. The reason is that they did a study at the same time that says rhodoxy levels in the mucosa different in men and women, and they were the same. So I think it's going to be adherence. And maybe women didn't think they were as much at risk. That's what happened with FemPrep and Voice. So they collected hair in the study. We're going to do actually doxycycline levels in hair, and we're going to see if it was adherence. That's going to be my hypothesis. And then I'm so sorry, I didn't understand the next question about IPREX. What was the exact question? Or I can look at the chat actually.
Okay, maybe later. It was actually a slide. I was so confused, but maybe
because
it was actually.
Okay,
go ahead.
I mean, one thing I will say is that IPREX, was the first study, IPREX-Olay specifically, that showed us that men just have to take 4 doses a week for PrEP, and for so long we thought women needed higher levels of adherence, like 7 doses a week. And I just thought, I really wanted to show you that study that showed demonstration projects, men and women, they just had to take the same amount, 4 doses a week.
Hey, Monica, would you mind stop sharing your screen?
Oh, yes, sorry.
Monica, there's a question on tenofovir TAF and TDF, the weight impact. One it reduces, one increases. Does it work the same for PrEP?
Yeah, that's a very good question. You know, in the Discover, all of these studies that I just told you about were in the context of treatment. So there was dolutegravir around. So that becomes harder to say. What's the pure effect of TAF versus TDF? The Discover trial, however, was the study that looked at TDF FTC every day versus TAF FTC every day for PrEP. And there was more weight gain in the TAF FTC and more weight loss in TDF FTC. So that's the purest that you can get for PrEP question. It's not very much, but it's true. TAF FTC leads to more weight gain, TDF FTC more weight loss.
And that might be something for folks who are taking PrEP. I just want to consider that in
Correct.
terms of their personal health. Okay, excellent. Do we have any other? Yanis has a question.
Yes, thank you, Monica. Really wonderful to hear your your insights. I had a question. I put it in the chat because I couldn't, for some reason, ask it in the Q&A. In your clinic, as you started, you showed, which was really interesting, the very limited use of long-acting cabotegravir for PrEP in the United States. And have you been trying to understand who is sort of showing up first to initiate cabotegravir long-acting for PrEP in your clinic or in San Francisco? And yeah, if you're doing some type of prioritization of sorts, what kind of protocols you have in place? Thank you.
Yes, no, it's such a good question because we're trying to use cabotegravir and rilpivirine as treatment in people who have viremia, and we're also trying to really enact cabotegravir PrEP because we think, well, it's superior, and also it's just easier for some people to take that, injection 6 times a year every 8 weeks. So we only have about 25 people on PrEP in our clinic with long-acting cabotegravir, and it's very intriguing. We have more women, cisgender women than men. So I do think that women have found this kind of an appealing agent. But how are we trying to, we're trying to advertise, we're trying to bring people in from the homeless encampments, because if anyone's been to San Francisco lately, it's really a increase in our homeless population, very unfortunately, during the pandemic. So we're really trying to push it for patients who it's just hard to take a pill every day. But can we get long-acting cabotegravir use up in the United States? Our healthcare system is so fractured. It's actually not that easy to get it. It's easier to get it on public insurance than private insurance. So we need more work to do, and we need the drug company to make it cheaper.
Thanks, Monica. Jeff.
Hi, thank you. Yes, Dr. Gandhi, thanks for great presentations. I'm curious what you think about new oral agents, if you think they're going to be necessary for people with multi-drug resistance or people who just, for whatever reason, can't or won't take long-acting. I'm concerned because a lot of the pharmaceutical companies have indicated that they're moving on from developing these, and as everything goes generic, there will be no new options unless it's a long-acting.
I think I completely agree with you. We haven't seen a lot of development about pills, about an oral agent that would it be, for example, could we take a once-a-month oral agent? I haven't seen that commitment, and I agree with you that I'm a little worried. Islatravir is as good as it gets, meaning that's all we have in terms of oral in the pipeline. Otherwise, everything that we're talking about in the pipeline are implants, TAF implants, something longer. I agree that we have to advocate in our community for more for more oral pills to be developed, because oral integrase inhibitors that don't cause weight gain, I think we have to do that advocacy because we always need new pills. It's a very good point.
Thank you. We have Yanis.
If there's others, they can ask before me, but I really also want, okay, just quick, Monica, WHO recommends the piperine ring, vaginal ring. The focus is really in terms of Eastern Southern Africa for implementation. But can you just like speak to why is it that maybe within Europe or North America, why are regulators thinking it's not as, why it could not be an additional option for cisgender women? I don't understand why we think it's like, not, and, why of not added utility to our HIV prevention efforts, even in high income settings. Thank you.
Yeah, I like you concerned that the FDA has not put the dapivirine vaginal ring on has not approved it for use in the US. Yes, it is less effective in the sense that you have to keep the ring in and all that, like it really depends, but it's still effective, and any choice, I mean, we just need choice. So I don't know, I'm upset. And I'm someone who works a lot with women, and I think we should have it as an option here in the US.
Is there anyone who has any questions? The clock is ticking.
Generic.
Yes. Hello.
Yes.
Oh.
Yeah. Are you getting me?
Go ahead, ask your question.
All right. I think that was background noise.
Was it? Okay.
Yes.
Sorry, Jim, I don't see it.
Okay. Hello.
Hi there, Owen. Do you have a question?
Yes, I have a question.
Yeah, go ahead.
Yeah, Monica, the long-acting injectable treatment, not prevention, but treatment. The guidelines in Zambia, they say you have to, when initiating, someone has to be very suppressed. Why is it like that? And if someone is very suppressed, then you initiate the drug, then what happens? Then maybe there's a blip which happens when the injection fails to clear. What will happen?
Yeah, I mean, the rules everywhere, Zambia, everywhere. It says FDA, Europe says that don't start long-acting cabotegravir and rilpivirine unless someone is already suppressed on oral therapy. That's because the clinical trials, which were called, Flare and Atlas, only studied it.
My main question is, why should you start with someone who's already very suppressed when if really the injectable can work to clear the viral load, even if you start at a high viral load?
Yeah, I totally agree. Right now, they've only approved it because they were going by the clinical trials, but I totally agree. And that's why we used it in people who had high viral loads in our clinic. We showed good results, just as good as the clinical trials. And we're hoping that our study and others will push the envelope to say, let's let it be started in people who have viremia, because those are patients who often need the long acting. It's hard to take pills every day for lots of reasons. So I'm on board with you completely. I want it to be started in people who have high viral loads, and that's why we're doing it in our clinic.
Thank you for that great question. I want to thank Devan, my co-moderator, Monica, all 22 scholars, most of who you saw today, Yanis, and the wonderful team from WHO and our Ukrainian translators. This has been a really exciting webinar and some really exciting science, right, that could really change policy and program. The last question from Owen in discussion with Monica about long-acting cabotegravir and rilpivirine for treatment. If we can change policy to get that into the hands of people who are resistant or have viral loads and things like that, would be amazing. I'm super excited myself about what we can do for oral PrEP and cisgender women. I think we've been telling cisgender women the world over that oral PrEP really doesn't work for you. And if you do use it, you have to be a super person and adhere 6 or 7 times a week. And seeing data that says that's not true is really major and should really change policy and program and recommendations all over. And I'm sure there's all kinds of other examples that came up during this webinar. I want to thank everyone for joining us, for being here. We will be sending you a follow-up email with the resources from this webinar posted online, including a recording and the slides. And I know WHO Ukraine is going to be working on Ukrainian translation of the slides. We're happy to share that translation as well with our materials. So I guess without further ado, I look forward to seeing everyone at the next the next Choice Agenda webinar on MPOX. And then in April, we're doing that webinar on MPTs and DPP, the dual prevention pill and multipurpose technologies. And we have some really great stuff coming up in May, June, and beyond. So I look forward to seeing you all early and often. With that said, I'm going to officially close out this webinar and wish you all a wonderful day, afternoon, evening, tomorrow, whatever the case may be. Take good care.
Bye, everybody. Stay well and safe.
Thank you.
Thank you.
Thank you. Thank you.
Jim, just hang on for just a little bit. And hopefully I just stopped the recording. And have a good rest of the day, everybody. Thank you.